Good morning. My name's James Stanger. I'm an embryologist and I'd like to present a small video on my IVF cycle management portfolio. This one looking at what is the best luteal phase support for IVF. Once again, I'm an embryologist or retired, not a clinician. This is actually clinical advice. So all I can do is direct you to the paper, which is open access, published in Reproductive Biomedicine Online by a series of distinguished authors. And it's for you to read the article and make your own conclusions. But open access. And so a lot of the information I'm presenting here will be direct quoting from that paper. Once again, because I'm not a clinician, I'm very conscious that this information is clinical advice. But by way of introduction, the authors say during assisted reproductive technology, a critical phase of natural and stimulated cycles is the midterm phase in which the implantation of the embryo is anticipated to occur. The need for luteal phase support in fresh embryo transfers using gonadotrophins for ovarian stimulation however, has only been accepted relatively recently. And for those who are really unfamiliar with what we're talking about, this is the ovary that contains a growing follicle, which at some point in time will grow and rupture and release the oocyte under the impact of this hormone here, this green hormone, luteal phase, which is a sharp beak, rises very quickly, induces ovulation, then falls, and the ruptured follicle then turns into a huge endocrine-producing organ called the corpus luteum that produces estrogen and progesterone for the next quarter, next 12 weeks. And basically what happens is a normal cycle, the corpus luteum produces lots of progesterone and estrogen, progesterone. Then as soon as the pregnancy occurs, it produces a HCG, which supports the corpus luteum. Without the HCG, it regresses and is resolved in women menstruates, it starts again. But there's HCG that then can keep the corpus luteum functional until 12 weeks, at which point in time, for the last second, third quarter, the pregnancy or trimesters, the pregnancy makes its own progesterone and estrogen, and the corpus luteum then regresses. So in ovarian stimulation cycles with IVF and fresh embryo transfers, the luteal phase support can be achieved by stimulating the existing corpus luteum by administering a gonadotrophin-releasing hormone, GnRH, or an agonist, or HCG, and in addition to providing supplementary progesterone activity. And the European, the ESTRA has produced guidelines for the use, and they recommend the use of progesterone for the luteal phase support after IVF and ICSI, either by vaginal progesterone, intramuscular progesterone, oral progesterone, and subcutaneous progesterone, and also gives the frequency and doses and stuff, so people can be referred to that if they're interested. But another critical aspect that's been overlooked is the route of administration. Despite the potential implications, route-specific pharmacokinetic effects are known to be modulated by first-pass metabolism in the liver and direct first-pass uterus to uterus, whereas injectable formulations typically have a much higher systemic exposure that can substantially affect efficacy. Given the absence of an established standard of care for fresh cycle luteal phase support, understanding the comparative effectiveness of different administration routes is of notable practical importance. So basically what they're saying is that if you use vaginal pessaries, the progesterone is absorbed by the vaginal arterial system, which gets into the arterial system and then into the uterine artery, which can then affect the development of the endometrium. Normally what happens is in the corpus luteum in the ovary produces progesterone, which passes down the ovarian artery into the plexus here, the uterine artery, and affects endometrial development. Oral progesterone has to go through the liver first, which is then transformed and arises by the internal iliac artery, as does intramuscular injection. But I know from my own personal experience that very early on, vaginal pessaries can be unreliable and not always necessarily delivering the goods, but it's very hard to measure. You can measure arterial progesterone, but sometimes it's quite hard to know what's actually effectively getting to the endometrium. And if there's insufficient progesterone, you will miscarry. It's that simple. And when we first started using pessaries back in the early 80s, there were, until the dose was correct, some pregnancies were lost because the dose was insufficient. So this paper looked at 24 studies that included the analysis of clinical pregnancy rates by route of administration, providing 28 pairwise comparisons of 4 routes: vaginal, intramuscular, oral, subcutaneous, compared to placebo, with a total of 11,000 observations. And a bit of risk management. The first one is clinical pregnancy, and this is what the authors say. This is figure 3. Well, actually, it's figure 6, actually. The 24 studies, including the analysis of clinical pregnancy rates by route of administration, provided 28 pairwise comparisons, 4 routes with a total of 11,000 observations. Oral administration showed a significantly higher relative risk of clinical pregnancy, whereas no significant differences were found in intramuscular, subcutaneous, or vaginal exposure. But this is the important figure 7. This is looking at live birth, the efficacy of routes on live birth rates. So this is actually the only important table. The other one, I think, was a distraction. 11 studies reported live birth rates. So there's only 11 studies that they're able to access, providing 13 pairwise comparisons of 4 administered routes for a total of 5,000 observations. So considering IVF's been going for 50 years, it's pretty disappointing. There's only 11 studies that the authors could use. And I think both oral administration and intramuscular injection showed a statistically significant improvement, reporting relative risk rates of 4.1 and 4.33, respectively, whereas vaginal relative risk rates and subcutaneous injections did not compare to placebo. So this is the relative risk of getting a live birth, and these are the only two which are significant, but it's only just significant. But the vaginal and subcutaneous are only just non-significant. However, they're different. So just a few quick implications for clinical practice and future research. This is what the authors have to say. It's not me. What does this mean for clinical practice? There is no accepted minimum clinically important difference, the smallest benefit that would make a treatment worthwhile in reproductive medicine. So there's no accepted minimum difference you have to get to. An absolute improvement of, say, 5% or less may be considered negligible based on only translating 1 additional live birth for every 20 treatment cycles. But placing this in a global context, an improvement of 1% would create many thousands of additional live births each year. Furthermore, it has been shown that the success rates of clinics was one of the 2 most important criteria used when selecting an IVF clinic, even though reported difference between clinics are relatively or frequently smaller than 5%. Live birth rate is generally accepted as the preferred outcome for clinical trials for ART. However, about 1/3 of Cochrane reviews with live birth listed as the primary outcome contain no live birth data. At the present analysis, only 12 studies were reported pregnancies confirmed by ultrasound and 14 reported live birth rates, highlighting the importance of consistent reporting of viable pregnancies and live birth rates to enable robust comparisons between individual progesterone products, routes of administration, and both. And considering the difference here is not the establishment of pregnancy, but miscarriage, I would have thought that live birth data was critical. Most people just can't afford to wait the 2 years to get live birth data. That's a problem. So in conclusion, this is what the authors have said. Combining evidence for all randomized controlled trials into a single network meta-analysis suggested that currently recommended luteal-phase progesterones administered by intramuscular and oral routes are likely to provide a significant benefit over placebos for live birth in fresh cycle treatments. However, in 2014, vaginal progestins were administered alone in 70% of supplanted cycles, vaginal route remaining the predominant delivery route, whereas the use of oral progesterone is still limited to around about 3%, and the use of intramuscular progesterone has declined about 5%, despite word evidence to support their clinical benefits. So on this basis, the present study, a network meta-analysis, supports the conclusion from other comprehensive reviews and meta-analysis suggesting that the trend to use vaginal progesterone preparations almost exclusively may not be delivering optimal outcomes. And that evidence is insufficient to support the assumption that intramuscular injections and vaginal administration of the telophase progestins are equivalent in IVF pregnancy outcomes. So that's a subtle way of saying that the current methods that use vaginal penetrance is not giving people the best likelihood of live birth. These findings, based on multi-layers of sensitivity analysis and robust evidence synthesis, following current methodological standards, may assist clinicians in identifying optimal treatments for individual cases, taking into account other factors such as treatment tolerability, patient preferences, cultural considerations, financial cost, and drug availability. So even though vaginal pessaries may not be the absolute best in terms of maintaining a pregnancy to live birth, there are many reasons why clinicians may prefer to recommend it. Once again, I'm not a doctor, but I've been involved in IVF since 1982, and the telophase support has always been part of clinical management. And so my comments are these. Improvements in IVF management. This is not medical advice. Improvements in IVF management often go at a snail pace, and the telophase support is one example, especially when it needs to be given several weeks, and so 12 weeks is a long time. The only real aim is a live birth, and any other outcome has little meaning. You can't be half pregnant. So looking at clinical pregnancy rates is a half pregnant scenario. The only thing you should be looking at in terms of luteal phase support is live birth and the health of the mother and the baby. Supporting a hard-won pregnancy with the best luteal phase support is admirable, but as this paper shows, best is not always the easiest or appropriate. Vaginal luteal phase support is by far and away the most popular because women can self-administer, while intramuscular injections is far more problematic, but is marginally better, not by a lot, just a bit, say 5%. But remember, that's one injection a day, whereas the pessaries are normally 4 pessaries a day. So it's really quite invasive for women, and a lot of women do complain about it, so I'm told. It's easier for clinics to provide the pessaries and send the women home, but variations in how vaginal delivery progesterone work make it less effective in supporting the pregnancy. No, I'm not a clinician. It's not clinical advice. But my comment would be that if my partner is going through IVF, I think women should be given the information and given the choice, and they can decide how they wish their telophase support to be given if they fall pregnant. So once again, my name is James Danger. I'm an embryologist with 150 years experience. These videos are my FertAid's YouTube channel, are my attempts to bridge the gap between information you may need for your fertility treatment and the most recent publications available to your clinic staff. I'm a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice you receive. If you like what I'm doing, please press subscribe or like or tell everyone and leave a comment. I just acknowledge this is supported by my other thing, providing online EQA support for embryology and andrology. And as always, my last slide is to thank you for persevering to the end of the video. I understand IVF as a personal journey that involves the actions of many different techniques, arguments, information, and advice, and many people, of course. It helps to understand that all aspects of that journey, and I hope this information may be of value. At this point in time, I'd like to say thank you for watching and goodbye.